we're gonna so as you know, the PFR got canceled, and
right.
yeah, that we'll have it. Looks like we're gonna have it virtually. So we're working on that now. So
right. Okay.
We'll
Within a 100-kilometer radius of where we sit today, there are more than 24 unreached people groups, and the population that's in the vicinity of 10 million people that Memorial Christian Hospital is actively striving to serve, both medically and to serve with the gospel. Memorial Christian Hospital opened in 1966. 54 years later, the new Memorial Christian Hospital is having a dedication, and we're celebrating the opening of the Furman Surgery and Critical Care Center. It is a dramatic, marvelous expansion of all that God led us to do here in the first place 54 years ago.
As I walked down the sidewalk into the building, one word kept coming to mind, and that was unbelievable.
Memorial Christian Hospital, you are well placed here to provide medicine, to use the skills that God has equipped you with to be able to help those that are hurting.
The capabilities of the Furman Center for Surgery and Critical Care are so crucial to who we are and to what we do. It's really the heartbeat of what we do, which is surgical care, critical care, complex care. Tirto Tripura is a 6-year-old little boy, and he got clipped by a vehicle, has an open fracture of his right tib and his fib. This surgery is an absolute game changer, and he'll be back on his feet this afternoon with crutches. He'll be getting his rods out within 3 months.
I watched the caring doctors and the nurses giving modern medicine, modern care and techniques to this hurting child. As a father, that crushes me. I want my own child to get the very best care, and that's what they get here at this hospital.
The new facility is triple the size of the old facility. We're now at 130,000 square feet. The capacity to expand our services and reach more people with the healing that modern medicine can bring in conjunction with the healing that the gospel brings to broken lives is exhilarating.
Yesterday, when I went on the ward rounds with Dr. Stephen Kelly and the medical team, I just saw miracle after miracle. So many people that are impoverished and without health care, and here they come to a Christian facility that provides excellence of medicine and the love of Christ. It's just miraculous.
This hospital is a magnet. It brings all of these patients in here, and then the platform for us telling them about Jesus.
Samaritan's Purse supports this hospital because they're centered right in the heart of Hindu and Muslims. We have the opportunity to share the truth, the love of Jesus Christ with those that are hurting and that are in need.
We need to pray for fertile soil, that people's hearts would be ripe to hear gospel truth. My hope for the future is that all of those 24 unreached people groups become reached within my lifetime. Humanly speaking, that's laughable, but the Lord is able to turn that around on a dime to bring people to the light of the gospel.
My name is Dr. Lance Flyler. I'm the director of World Medical Mission at Samaritan's Purse. We are in the country of Zambia at Chitokoloki Mission Hospital. World Medical Mission has sent volunteer doctors here to this hospital for many years to help these people. When I come here, it can't help but grab your heart because you see these people with disease and it's so advanced.
Some of these mothers and fathers come so far just to get to these hospitals here, and it's so important that World Medical Mission is helping provide medical equipment and doctors so we can help keep these hospitals going and provide the health care for these families in the name of Jesus.
You can just see behind me, I mean, this hospital is filled. And I can honestly say at being at so many of these mission hospitals, there's not nearly enough doctors and way too many patients. So just this morning, we went on rounds with one of our volunteer doctors and he saw over 110 patients. Hospitals like Chitokoloki could not survive were it not for volunteers that come out and serve.
I'm Dick Furman with World Medical Mission. We started this post-residency program where we were asking doctors who felt called to full-time mission work to apply. It's evident these hospitals would be closed 10 years from now, 15 years from now, if it weren't for these young doctors that are giving their lives to the Lord in full-time service. Many of the hospitals that we are supplying with post-residents now are blossoming back to like they used to be 20 years ago with the spiritual impact, with the medical impact. And that's going to allow these hospitals to continue on for years to come.
Boy, girl, girl. Name? No name yet? No name. This morning, when I got to go around the maternity ward with you, was so special. And I know for many moms back at home that to hear that heartbeat is a special connection for the first time. But the thought that many mothers don't hear the heartbeat until that baby comes out. And when you brought this tool out, I thought you were teasing me.
It's yours.
I don't hear anything.
Let me see.
This is
Thank you very
for
much.
a hospital.
Thank you very much.
And to be a part of Samaritan's Purse and World Medical Mission, to be able to partner with hospitals and staff that work so hard, and to be able to help provide medical equipment, it's just pretty special to be a part of.
Thank you very much.
That's your baby's heartbeat. You can hear it.
Wonderful.
One of the hospitals we just came from, they have not had a functioning X-ray machine for several weeks now. That's devastating to the hospital. So many of these patients are in dire need of X-ray imaging to help diagnose and treat their ailments. And so it's essential that WorldMed continue to provide these medical supplies like the X-ray machines so that these hospitals can continue to serve the people of Zambia.
It is so important that we keep these hospitals alive because it provides so much for a family, especially for women and children in these communities.
Samaritan's Purse goes out to the ends of the earth to meet the needs of people that are poor and have advanced disease that would not have help otherwise, and we're meeting those needs.
When I was in fourth year in medical school, I went to India on an elective. The only group of patients we saw who were dying in numbers that shouldn't really were the maternity patients. The Lord burdened me with that and gave me a desire to be involved in addressing some of those injustices. We read Matthew 25, and Jesus talking about whatever you did for the least of these, my brothers and sisters, what you're doing for me. My mama. So the least of these tends to often be in third world women who are sick. You want to feel you had a spinal. And take another rung down the ladder would be the woman with pelvic floor disorders. They can't even tell their own husbands. It's the shame and the stigma associated with those things. That desire to be involved in overseas mission, we really felt like this was a good fit, and the Lord guided us here. The Samaritan's Purse post-residency program is perfect for a Christian doctor who has thought about missions, even long-term missions. The Samaritan's Purse is a bridge for that, because they help you with a lot of the logistics and spiritual preparation, and really this is kind of a unique opportunity which you really shouldn't miss. And the reason I love what I do is because I see patients who are really miserable with pelvic floor disorders, really truly the least of these. We do surgery, they go home, they come back after a couple of weeks, and they're absolutely overjoyed. They give me eggs. I've even got a chicken one time.
The way we express the love of Jesus Christ and the passion that he had is that we go out there and we serve others.
We go to the out-of-bound places, the ends of the earth.
The world is changing, but the gospel doesn't change. The message of the cross doesn't change. We're going to make every effort to share the gospel.
The world has been decimated by COVID-19, but the work here at Samaritan's Purse, it never stops. No greater need and no greater time than right now for us to go out and serve boldly in the name of Jesus Christ. During this pandemic, during all the fear that COVID-19 has brought to the world, this is when we go out and share the truth.
This is an opportunity to take the gospel to the ends of the earth. God has told us to go into the world, to make disciples of all nations. That great commission is still in play today. We have a job to do. And missionary medicine is one of the great tools for evangelism.
Is there a sense of urgency? Yes, there is. Get out there to be a part of this. Right now, it's the time.
In Jesus' name, amen.
So come, be a part of this. We need you.
All right. Hello, everyone. Welcome to another episode of Samaritan's Purse International Health Forum. As always, we're delighted to have you with us here today. Despite the pandemic, we're doing quite well here at Samaritan's Purse. As Christ followers, it's so good to have that reassurance. And so today, we also just want to reach out to you, our audience, and regardless of whether you participate with us through volunteerism at World Medical Mission, or perhaps through our surgical subspecialty teams, or even DART, we just want to express our appreciation to you for your service to us and to the Lord. And we just thank you for being here today. As always, also, I just want to encourage you, utilize your chat box. If you would, just put your name and maybe where you are from. I just think it makes it a little bit more personable for us just to know who is listening and just helps us out in that way. And before we get started with our presentation, as always, going to open up in a word of prayer. So just bow your head with me if you would. Dear Heavenly Father, what a delight it is just to be amongst brothers and sisters in Christ who are like-minded, who utilize medicine for the sake of the gospel. Thank you, Lord, for our speaker today, Dr. Bob Spencer. Lord, what a blessing he has been to our organization. Just speak through his words today. I pray that he imparts wisdom to us so that we all may serve better on the mission field. And ultimately just to present the gospel. And it's in Jesus Christ's name we do pray. Amen. So today it's just my honor to introduce Dr. Bob Spencer to you. Many of you all, of course, know him well, and he needs no introduction. Today he's going to be talking about management of heart failure in resource-limited settings. Just a little bit of background about Bob. He went to medical school and completed his internal medicine residency at the University of Mississippi. And as many of you all know, he is a board certified cardiologist. He did a fellowship in cardiology in Phoenix, Arizona at Good Samaritan Medical Center. He also completed a second fellowship in cardiac MRI in Humboldt University in Berlin, Germany. Dr. Bob lives with his wife, Linda, in Pensacola, Florida, and they have 2 adult sons. Presently, I know personally that Bob is very active. He serves on the committee here at World Medical Mission, and he also is very active with DART. Many of you all know he played a very integral role in our response in Italy with the COVID outbreak. So Dr. Spencer, what an honor it is to introduce you, management of heart failure in resource-limited settings.
Well, thank you, Lance. Thanks for inviting me here today, and I'm happy to be able to present this information to you. And what I really want to do is kind of communicate information that I've basically my experiences in trying to manage heart failure in resource-limited settings, and some of the things that I run into, and share those with you so that when you go into those situations, you'll be well prepared, or if you're actually serving in those situations, that you can make any adjustments that you might need to your practice. Next slide, please. So what really I'm going to kind of cover, and here's the objectives, but I want to take the American College of Cardiology and the European Society of Cardiology guidelines and kind of adapt them to practicing in a low resource setting. So these are settings in which you don't have cardiac MRI, you don't have a CT, you don't have ultrasound, you're not doing heart caths, you're not doing all those advanced imaging modalities, you're not putting in pacemakers and defibrillators. So it's really kind of bringing that therapy down to something that can be applied to a lot of people in a lot of locations that are really resource limited. That being said, some places where you travel, you might actually have medications that I'm not going to discuss because they're not FDA approved in the US. So we're not going to cover those. So it's just going to be kind of the bread and butter basics of cardiology management. Next slide, please. So here's your typical scenario. It's 5 o'clock in the afternoon. It's Friday. Everybody's thinking about, heading out the door, and your last patient of the day comes in. It's a man and his wife. They have walked 500 kilometers from Burkina Faso, and they've come to see you in the clinic, and he's got congestive heart failure. As is typical in many resource-limited settings, he brings his medical records with him. So he's got a printout of an ultrasound someone has done. He's got x-rays and lab work and actually a very detailed consultation. This gentleman has class 4 congestive failure. He cannot lie down on the exam table. You just marvel as to how in the world this guy in this poor of physical condition could actually have made the journey to get to where you are. So you immediately recommend that he be hospitalized so that you can begin to treat him. And he tells you, Doc, I don't have any money. I can't afford to stay in the hospital. And he also says, I can't afford to get any lab tests. So this is kind of where you are on a typical, Friday afternoon. Next slide, please. So when we look at heart failure, this is a definition that you can read on the screen. And there's 2 main classifications of heart failure, but there's now 3 that are kind of looked at, but we're going to ignore the one in the middle. So there's heart failure with reduced ejection fraction, which is the HFrEF. So those are people that have an ejection fraction less than 50%. And then there's HFpEF, heart failure with preserved ejection fraction, an ejection fraction greater than 50%. And that pretty much delineates the goals of our therapy, because there's been clinical studies that have kind of divided these 2 classes of patients up. So on the next slide, you'll see that when we see that patient, they come into the exam room, we're trying to figure out, when we're taking the history, what is it about this patient that makes me think, does this patient have heart failure? So the more sensitive items in your history are going to be orthopnea and paroxysmal nocturnal dyspnea. Do they wake up in the middle of the night short of breath? So these are very sensitive to find out if the patient has heart failure, but they're not specific, meaning if the patient has orthopnea, it doesn't mean they always have heart failure. They could have that from some other cause. So the more sensitive items are over on one side of the slide and the other less sensitive on the other. And you collect all this information in your history to try to assimilate where you're going in the future. And something that people don't understand, the one on the bottom, bendopnea. What is bendopnea? Well, that's when you bend over to tie your shoelaces. How long does it take you to catch your breath when you sit back up? Next slide. Then in your past medical history, you look for things there that will guide you into trying to make the diagnosis of heart failure. So if the patient has hypertension, angina, coronary risk factors, or diuretic use, these items in the red we're going to identify in another slide or 2 down. They should hone you in to make you think this could be heart failure. The other things that are very important while you're gathering this history is to try to figure out, if they do have heart failure, why do they have heart failure? So with alcohol use, it may be because the patient has an alcoholic cardiomyopathy. Pregnancy, they could have a postpartum cardiomyopathy. If you see that they have erythema nodosum, they could have sarcoidosis, hemochromatosis with bronzing of the skin, which you can see in some people. They could have a hypertrophic cardiomyopathy from that. Amyloidosis with bruising. Then the family history, you're going to dive into these family histories and see if people have a family history of people dying at an early age of a heart issue. And that's where we see things like the non-compaction cardiomyopathy. If that patient lives around the equator, well, then you have to think about, could they have endomyocardial fibrosis? And so these are particularly evident in Malawi and areas of Eastern Africa near this area. That's a very common pathology that you'll find. One that's kind of a newer cardiomyopathy and a newer cause of heart failure is Takotsubo's cardiomyopathy. This is from situational stress. Someone comes in and says, my dad died, my child died, and they're just distraught with this. And you have this neurohormonal event that happens, and it gives them a transient cardiomyopathy. Most of these will recover fairly quickly, but this is in fact a problem that can cause a cardiomyopathy and heart failure. Any form of congenital heart disease can be associated with heart failure. And unfortunately, what we've all seen within the past year is COVID. Upwards of 30% of the patients that have severe COVID and get admitted to the hospital can in fact have heart failure from a viral cardiomyopathy. Another one that's often overlooked is HIV. Particularly untreated HIV has a high incidence of cardiomyopathy and heart failure, but also those that are treated with HIV can develop a cardiomyopathy and heart failure. So those things you have to think about is, do they have heart failure? But also, as I get down to my treatment plan, I want to make sure that I treat things that have caused them to get the cardiomyopathy. Next slide. Then we look at the physical exam. Are there things in the physical exam that can lead us to think that this patient has heart failure? One of those is the hepatojugular reflex maneuver. So for those of you that may not be familiar with this, you actually place the patient at about 30 to 45 degrees head up in the supine position, and you press firmly over the liver for about 10 seconds, and you look at the neck veins to see if the neck veins become distended. You take your hand off the liver, and then you wait to see if that jugular venous pressure then goes back to baseline, or does it stay distended. If it stays distended for about 10 seconds, well, then that tells you that that patient has an elevated pulmonary capillary wedge pressure, and so they probably have some form of heart failure based on that maneuver. And then the other things you can see here that are in red are the ones that are more sensitive to giving you the diagnosis of heart failure. But all of this collectively can be taken to see, do they have heart failure as a diagnosis? Next slide, please. Then all of those things that we've seen in the red highlight are in this big box in the middle of the screen. So if they have two of those prior red symptoms or history or physical exam findings, if they have two or more of those, well, then more than likely they have heart failure. So then you would typically say, what can I do to assure my diagnosis? Well, on this table, based on all these Western guidelines, you get a natriuretic peptide. Well, you can't even get a CBC. How in the world are you going to get a natriuretic peptide? So you just, forget that. Don't even go there. If you can image their heart in some way, and I'm not telling you to go buy an echo machine, but if you have the ability to image their heart, stick the linear probe or the curved probe on their heart and just see if you can see what their heart's doing. If you can't, it's okay. Don't worry about it. Treat them for heart failure. But if you can image their heart, that may guide you as to whether or not this is reduced ejection fraction or preserved ejection fraction heart failure. Next slide. So now we're getting into the diagnostic test that you would use with treating that patient for their heart failure. Of course, again, the echocardiogram would be a great thing to have if you can get it. A lot of people now have a point of care ultrasound in their back pocket. You're going to whip that thing out and throw it on the patient's chest anyway. So that will help guide you. If you don't have that, you can think about getting a chest x-ray. But again, you don't have to have it. But the chest x-ray might help you also determine, do they have a lung cancer? Do they have pneumonia? In addition to having heart failure, do they have something else? Then we look at the lab test. The sodium is helpful to see if they have hyponatremia. If that patient presents with their episode of if that patient presents with their episode of heart failure and they have hyponatremia, they have a very poor prognosis. That just helps you on the front end determine where are we going for the long haul. Potassium's good because many of the therapies that we give the patient will affect the potassium. You're either going to make their potassium go down or their potassium go up. It's just kind of good to know where they are. And the same goes for their creatinine. Their glucose and their hemoglobin are important because if they have severe hyperglycemia, it may be that the hyperglycemia has provoked their heart failure. The same goes for a profound anemia. Is that why they're in heart failure today? And if you don't address these, you're not going to completely manage their heart failure. HIV, especially in many countries in which we serve, if they have HIV and it's undiagnosed, you'll want to begin to treat them for that also because, again, that will help your management of your heart failure. The other items on the slide are to be considered. The liver function test, I think we need to be aware of because some of the drugs we use will aggravate liver disease. Many of these patients with profound heart failure will have passive congestion of the liver, so that even though they don't have an underlying liver disease, the heart failure provokes liver insufficiency. And also I've seen many cases of heart failure in which the patient also has hypo or hyperthyroidism, and you'll need to address those because they're easy fixes. This is easy things you can do to try to help the patient. Next slide. Now, we cardiologists are pretty easy to read. We all come with our standard toolbox. The electrophysiologist, they've got their amiodarone. The interventionalist, he's got his Plavix. Well, the general cardiologist treating heart failure, we've got our diuretics. So we all come with our standard toolbox. These are the drugs we're going to use to treat heart failure. Next slide. This slide, I caution you, don't think that these are that a beta blocker gives you this survival. This is a slide that shows additive, and it's just kind of for that, big picture. Without any treatment at 5 years with heart failure with a reduced ejection fraction, their survival is somewhere around 35 to 40%. So if you do nothing, that's where your patient's going to end up. If you add an ACE inhibitor, you improve their survival. If you couple that with a beta blocker, you improve their survival. If you couple that with an aldosterone blocker, you increase their survival. So these are additive survivals, not a specific survival for each one of these drugs. That's kind of what I want to say is the more drugs that you can get the patient to take based on where they are, the better off there will be their survival. Next slide. So then we look at the global differences and the global similarities of heart failure. And when we see patients that are in Asia, South America, and Africa, typically that patient will present with their heart failure at a younger age. That patient also will have a lower ejection fraction. They will typically show up with an ejection fraction under 25%. The other bit of it that is kind of hard to wrap your head around is that in all of the clinical studies where these drugs have a justification for their use, if you look at all those studies added up, there's only 1,700 Blacks and 400 Asians in all of the clinical trials for drugs for heart failure to date so far in the English literature. Global similarities. Medical compliance. In resource-limited settings, the compliance for medical regimens is about 58%. And of course, most of you are thinking, oh, that's terrible. I can do better than that. Nope. In westernized societies and in resource-rich environments, complete compliance with a medical regimen for congestive heart failure is 58%. So you may think the patient's taking that drugs, they're not doing it. But what we do know is that if you can get a comprehensive follow-up program to follow those patients longitudinally over the long haul, you are going to improve their outcomes. Next slide. These next slides, the next couple, I went to East Africa and I went to West Africa. And the diseases that you see in the United States and what you're going to see in West and East Africa are exactly the same. So the image on the left is a patient that has an ischemic cardiomyopathy with a clot in the apex of the ventricle. The patient on the right has a dilated cardiomyopathy with 4-chamber cardiac enlargement. Next slide. Next slide. There we go. So the image on the left here is a patient with a hypertrophic cardiomyopathy, a really thickened heart. The image on the left is a patient with non-compaction cardiomyopathy. So I saw 2 patients with non-compaction cardiomyopathy in Africa and Kenya. And then I saw another patient with the same illness, same diagnosis in Togo 2 weeks later. Next slide. So when you think about the management of the acute heart failure, you have to come back and say, well, how'd this patient get here? The patient will begin to develop changes within the heart, which will cause a hemodynamic congestion long before they get short of breath. And so the difference between the hemodynamic congestion and when they begin to start having changes in the heart, I usually say that's about a 10-pound weight gain in fluid. So the patient can hide about 10 pounds of water before they're ever going to start getting short of breath. And in this time, your renin-angiotensin system and your sympathetic nervous system are trying to compensate for that derangement that's happening in your hemodynamics. Now, unfortunately, when the body is doing this, it is actually committing suicide. So the body's thinking it's trying to help itself get out of this deranged condition, but over the course of time, your renin system and your sympathetics will actually do detrimental things to your body. And that's why we direct all of these treatments, all of these drugs we're giving are trying to block these systems. So when you look at the treatment goal, you're blocking your renin system, you're blocking your sympathetics, all at the same time that you're trying to relieve the clinical congestion with your diuretic therapy. Next slide. So when you begin to see the patient, they show up either in the office or they show up in your triage area, your casualty area, wherever you're going to encounter that patient in heart failure. Really the first thing you do when you look at that patient is you try to stratify them in a triage. And I look at this as emergent comfort care or urgent medical therapy. You're going to see patients in that environment that will either consume your entire medical facility and all of your drugs and all of your people and still will not survive the event. Or you're going to have a patient that you know you can treat. So if that patient, when you identify them and they're more than likely, despite everything you can do, that patient is not going to survive, well, then you need to be sure that you're working on emergent comfort care. And most people think of emergent comfort care as palliative care. I think of that care as urgent concentration to assure their salvation. You really need to spend the time with that patient and that family to make sure that they have a right relationship with Christ. Primary goal of all of our interactions, but that patient may need more of that concentration at that time than the next patient in the next bed. So then we get to how we're going to relieve that patient, whether they're the comfort care or the urgent care, how we're going to relieve them of that acute anxiety and stress of breathlessness that's in their face. You're going to give them a diuretic. Typically, you're going to give them furosemide because that's the most widely available. And I would say give them at least an 80 milligram dose IV if you can get it. If you can't give them an IV dose, give them 80 or 120 milligrams of oral furosemide just to prompt the diuresis to get that acute volume overload relieved. If you have oxygen, use it cautiously. If you give them too much oxygen, you actually can cause vasoconstriction. So you want to get their saturation 88 to 92%, but you really don't want to just put them on 100% non-rebreather if they don't need it, because you could actually vasoconstrict them and make them worse. And the other thing is trying to put a face mask on a patient when they can't breathe, they're going to fight you anyway. Based on their blood pressure, you would want to try to give them nitroglycerin or hydralazine and try to help with some of that volume status also. Next slide. So this is a complex slide. Don't pay any attention to it. The stuff in the red over here is mainly if you're going to resuscitate them. We're not resuscitating people. So we want to concentrate on that little box in the middle. So the middle one is you want to look and see if they have concomitant other diseases. Do they have acute coronary syndrome? Are they hypertensive? Do they have rapid atrial fibrillation? Do they have a pulmonary embolus? You want to also direct your treatment along that line. Next slide. So then we get into the hospital phase. The patient is a little bit better. You got them in a bed in the ward. Now comes how you're going to manage them. We're going to fluid restrict that patient. If you diurese 2 liters, they drink 2 liters, we made no progress. So you want to fluid restrict them as you possibly can. You also want to sodium restrict them. Most people think of furosemide as a water pill, but it's not actually a water pill. It actually causes the kidney to excrete sodium, and the sodium drags the water along with them. So if they excrete 2 grams of sodium and they eat 2 grams of sodium, we didn't make any progress. Try to get your nursing staff and your other staff to work along with you so that you can measure the daily progress of the patient. What are their weights doing? Are they actually losing weight? Are they actually having a negative balance of their fluid? And with that, you want to just follow that patient along and engage your nursing staff into the care of the patient and teach them and help them understand what your goals are and how to help this patient. Toes above the nose, water goes downhill. If you give the patient a diuretic and that patient sits in a chair, the fluid is going to stay in their feet. There's nothing in the body that will mechanically make that fluid that's out in the flesh get back to the heart so the heart can pump it to the kidneys. So you actually have to raise the foot of the bed so that their feet are higher than their heart. Gravity will take place and that fluid will come up to the heart. The heart can then get it and then send it to the kidneys to be excreted. So after every dose of diuretic, you want them to have their legs elevated above the heart for about 2 hours. And of course, they'll have to get up and go to the bathroom or whatever, but you still want that action to take place. Give them furosemide as the best option. Typically give it IV as best as you can. You can combine diuretics, but then you run the risk of running into hypokalemia. So if you can get by with one, that's fine. Based on where they are, I would use a mineralocorticoid receptor agonist, basically spironolactone, because it's also a diuretic, but it also will help keep their potassium up. If you give them a drug like an ACE inhibitor or an angiotensin receptor blocker, an ACE or an ARB, that will help them as with its vasodilatory effects in blocking the renin-angiotensin system, but it also will keep their potassium up. Potassium's hard to come by, it's expensive. Try to use these other drugs to get you where you're going. The other piece of this is that as you're treating that patient, and this is common, people always want to bring that blood pressure down. Oh, I got to get that blood pressure down to 120/80, but try to resist doing that. The diuresis over the course of the next several days is a good antihypertensive regimen. And the risk you run if you try to make that blood pressure come down to normal on hospital day 1 is now their blood pressure is normal, and then you keep giving them the diuretics over the next 5 days, and they become hypotensive. So when that patient becomes hypotensive, you now have caused an acute renal injury. And if we look at the next slide, the thing that you run into is the risk of a cardiorenal syndrome. If you dry them out too fast and drop their blood pressure too low, you cause an acute renal injury, and at that point, the patient is at risk of a worsened outcome. Those patients will end up with a shortened lifespan. So I really try to get the nursing staff and the physicians not to chase the blood pressure in the first few days. That patient's been at home with a blood pressure of 220/130 for the past 5 years. You don't need to correct it tonight. So you just kind of let this thing come down and work at it over the course of days. Next slide. Then we get into discharge planning. We now will get to the point to where we can convert the patient from an IV diuretic to an oral diuretic. And if they can maintain a gradual volume reduction with the oral diuretic, you can say, okay, I can think about sending them home now. If I'm still having to give them IV diuretics because the orals aren't working as well, well, then they're not ready to go home. At this point, you typically have them on an ACE inhibitor or an ARB. You probably have started some low dose of a beta blocker. They're on a diuretic. They're on spironolactone. So that's kind of a good group of meds to have them on. And now we can send them home. we need to set up an appointment within 1 to 2 weeks of discharge, because the real management of heart failure begins now, because you're going to have to titrate these drugs over the course of several weeks to months. Next slide. With heart failure with reduced ejection fraction, these medications will improve their survival. And you have to use many of these medicines, not all of them, but you've got to use these medications to change their survival. Whereas heart failure with preserved ejection fraction, it's not as critical that you use all of these medicines to change their survival. Next slide. And so the physician will go to the toolbox, goes to the bottom drawer where the big tools are, and you've got your diuretics. So take your camera out, take your phone out, take your camera, take a picture of this. This slide tells you the dose of drugs where you typically start, and then later on we're going to get to the maximum of some of these drugs. Not necessarily these, but these will have some maximums that I'll get to in a second. So for your furosemide, you're going to start at 80 milligrams once or twice a day, IV to begin with, PO afterwards, and then you're going to titrate that drug to get that patient's dyspnea and breathlessness resolved. Then over the course of time, you're going to drop that dose back down. You're going to combine that with the spironolactone classically down at the bottom. And so that patient will be on like 25 milligrams once a day. If that patient's not responding, you can go up to 600 milligrams of furosemide a day if you need to. If you need to, you can use 100 milligrams of spironolactone a day. You can use these higher doses if you need it to get where you need to get in the heat of the moment. So this slide is for the relief of symptoms, and you can use these maximum doses to get to the relief of symptoms. Once you get to the relief of the symptoms, then you're going to pull those doses down to where they're more manageable for a long term. Next slide. Then we're going to go to a next higher drawer where we can get the hammers out. And with these, they're the ACE inhibitors and the ARBs. These drugs are for the prevention of disease progression, and these drugs are for survival benefit. Take your camera out, take a picture. The initial dose is what you'll see, say, for captopril, 6.25 milligrams 3 times a day. That patient's survival, that graph I showed you before where their survival was increased, their survival is only increased if you approach the 50 milligrams 3 times a day. If you see that patient at the time of discharge and you put them on 6.25 milligrams 3 times a day, and then you send them home and you never increase that drug above 6.25 milligrams 3 times a day, their prognosis is the same as if you never treated them at all. So that's why it's so important that we see these patients on a regular basis, and every 2 weeks, you're trying to increase these drugs. So if you're using enalapril, your goal is try to get to 20 milligrams twice a day. You may never get there. They may be hypotensive to where you can only get them on 5 milligrams twice a day. That's okay. That's the maximum dose that that patient can tolerate. That patient still has a survival benefit. When we look at the classes of drugs, you always want to try to have that patient on an ACE inhibitor or an ARB, but don't use them together. Using an ACE with an ARB actually causes a worsened outcome. Next slide. So then we go to the beta blockers. The old standby is carvedilol. It's been out there forever. We also use metoprolol. It's widely available in many resource-limited settings, and also bisoprolol. Just like your ACE inhibitors, you're trying to titrate these drugs. To me, it really doesn't matter if you titrate the ACE inhibitor one visit, the beta blocker the next visit, or you take or what you do, but you're going to inch these drugs up as their blood pressure allows over the course of time. In many places, you have atenolol, and people will go, well, I can't use atenolol. There's never been any clinical trials that said atenolol will treat heart failure. Go back to when we started learning about treatment of heart failure with beta blockers. Atenolol had just gone generic. So no one's going to spend multi-million dollars to see whether or not atenolol would be a good beta blocker for heart failure when they're not going to make any money on it. But atenolol, there were a few little pilot studies that did show that atenolol is just as good at treating heart failure as metoprolol or carvedilol. The thing about atenolol is it is excreted through the kidney. So you treat your patient with atenolol, you got them on a dose, you send them out, a month later they come back. Previously their heart rate was 80, now their heart rate's 40, and you panic. Oh no. No, that's actually a good thing. That lets you know that you reached the dose that they can tolerate of either their diuretic or their ACE inhibitor. So what you do is you typically will hold a dose of each of your diuretics or your beta blocker and your ACE inhibitor. Hold a dose so that they kind of get out of that pre-renal volume contracted state, and then you kind of half the dose of all of those, and then send them out and see them back in a week or two, and typically they're going to get better. But that kind of lets you know the floor of your limit of where you can go. Next slide. And so next we go to the spironolactone and these other agents. The ones at the top, your mineralocorticoid receptor agonists and your vasodilators do prolong life. Those at the bottom only treat symptoms. So with your mineralocorticoid receptor agonist, we're typically using spironolactone because it's generic. That will help improve their survival. And there's the doses that you see. The vasodilators, which is your hydralazine isosorbide, either in a fixed dose combination or in the individual drugs that the patient will buy. The disadvantages of these is they have to be given 3 times a day to be effective. And to improve survival, the survival studies were only done in combination with the ACE inhibitor, the beta blocker, and the diuretic. They work really well in improving survival if they're used in combination, but they don't improve survival if used alone. That being said, they are very good alone to treat symptoms. So if you have particularly Black people, because that's where they're most effective, of African descent many times, those people are going to get the most benefit from these for their symptoms or survival if used with the other drugs. Less so in Asians or European descent. They can still be used, feel free to use them. Digoxin is a drug we have to be careful about because of toxicity. I would say in heart failure, we probably should not use more than 0.125 milligrams once a day. And you should, I don't ever use dig levels. I think they waste money and many times they don't guide us as well. I just check their pulse and see where their pulse is going. If they used to have atrial fibrillation and you know that they have atrial fibrillation, they've had long-standing atrial fibrillation, and you check their pulse and now it's regular, they're beginning, that's one of the first signs of dig toxicity, even when the dig level would be normal. So just count their pulse and see where their heart rates are going and see what you're doing with that. The phosphodiesterase inhibitors, the sildenafil and the tadalafil, those will treat symptoms, but they don't improve survival. So to me, those are kind of like add-ons. And the reason I don't push a lot of this stuff is in resource-limited settings, if you try to get the patient to take 6 drugs, they can't afford it. And if they can't afford it, they also can't find it. There's no pharmacy around that even stocks 6 different drugs that they're going to need to take every month. So you're really going to figure out which of these your patient can take. Next slide. The other bit about treating heart failure is that patient comes back in and says, Doc, I've been taking all these pills, and you count their pills and they lay them out there, they're not getting better. And this applies even for your own internal hospital formulary, is somewhere between 5 to 40% of the drugs in most of these countries are phony. They're just fake. They're not even drugs. And some Asian countries, that can be 88% of the drugs. Next slide. So the next thing that you look at is the heart failure management with preserved ejection fraction. How is that different? Well, the signs are pretty much the same. The signs and symptoms are the same, but in these, the ejection fraction is higher. You still go back and look, what else could have provoked it as far as the acute event? Now, this is where if you have it in your pocket, you're going to do it anyway because you got it in your hand, and you say, well, is this diastolic heart failure or is this systolic heart failure? Well, you can kind of eyeball the heart and see if it pumps well. Is it doing this number? And say, well, it looks like it's pumping pretty well, but I don't know if it's diastolic heart failure or not, because my point of care ultrasound does not have pulse wave or continuous wave Doppler where I can see the E to A changes on my waveform, because I can't get it. So what you do is you, in these views, and this is not telling you to go buy an ultrasound machine, on the image on the left, you see the aorta and the left atrium and the left ventricle. If your left atrium is bigger than your aorta, they have left atrial enlargement. That is a sign of diastolic heart failure. If the left ventricle, which is the image on the right, the left ventricle pumps reasonably normally as far as you can see it pumping at, in and out, 50% of the chamber size gets smaller, and they typically would have left ventricular hypertrophy. So you have these little markers over here where you can measure the thickness. If their left ventricle is greater than 1 centimeter, well, they probably have left ventricular hypertrophy, and that's kind of a poor man's way of saying they have diastolic heart failure. Next slide. So in the management of heart failure with preserved ejection fraction, from what you remember before, the only medicine that really changes their prognosis is spironolactone. So you really want to have those patients on spironolactone if they can find it or afford it. All the other medications can be used, but instead of saying, I've got to have the patient on a beta blocker, I have to have the patients on an ACE inhibitor, I have to have the patient on all these different drugs because it changes their prognosis, I can say, I can max out my ACE inhibitor and before I even think about starting a beta blocker. So it gets to be in resource limited settings, what can I use to get that patient treated the best? The other thing is the calcium channel blockers, your verapamil and diltiazem, are relatively contraindicated in heart failure with reduced ejection fraction. You can use them in heart failure with preserved ejection fraction. Also, you want to look for your comorbid conditions. Many times in something like heart failure with preserved ejection fraction, it's going to be associated with obesity, obstructive sleep apnea, chronic kidney disease, and many of these patients will have atrial fib. So you're going to treat those issues also. I thought this was amusing. I was in Congo and I went to the grocery store and I saw the anti-heart failure tea. I really should have bought some. I probably could have made a mint on it, but I don't think it's approved for use in heart failure. Next slide. So back to the patient that came in. So Monday, the patient comes back from having put on this treatment. And so I had treated him mostly with a huge dose of prayer, but I had also given a prescription for 120 milligrams of furosemide 3 times a day, 25 milligrams of spironolactone twice a day, metoprolol 25 milligrams twice a day, digoxin 0.125 milligrams daily, lisinopril 20 milligrams daily. On Monday, he comes back in the office, surprised to even see him alive, 20 pounds lighter and in class 2 heart failure. And he tells me he doesn't know why he even came to the hospital, doesn't really know why he's there, but a voice inside him told him to come. He and his family are Muslim, and he is open to hearing about Christ, but they're not willing to accept Christ at this point. But he did bring his extended family with him on this journey, and they're all willing to come back each week or each 2 weeks as Ibrahim and the other PAs and staff titrate his medications. What I did is I gave them a very detailed list of the medications and how to titrate those drugs up over several weeks. So I had to give the local country staff instructions in how to titrate up these medications, but they already knew how to titrate the gospel. Next slide. So in summary, we have to use all the tools that we have in our toolbox. So on the left, we have the front end loader of the tractor putting the generator in the generator shed. And what's written on the side of this is in Swahili, plow the field with the tools you have. So whatever tools you've got in your toolbox, whatever diuretic you got, when the patient comes in short of breath, break out the big tools, get the big stuff, and get the patient out of their distress. So in the top right, you see that we've got the piece of the trapeze bar stuck in the front of the engine, trying to rotate it until we get the timing marks timed up to make the engine run. And so that's where you're in the hospital and you're trying to just, well, can I give them a little bit more ACE inhibitor today? Maybe I need to cut back on the diuretic today because they're getting a little hypotensive or they're a little orthostatic. So you're sitting there and you're just dialing up and down these medicines in the hospital. And there's no right or wrong answer. You can go up on the ACE inhibitor, you can go up on the beta blocker, just inch those up until you can get the patient to where they can eventually get on an oral regimen that you think is good enough for them to go home on. And then on the bottom right image, you use your bronchoscope and your fiber optic endoscope to actually peer inside the engine. And you want to begin to explore in your healthcare system. How can you train your nursing staff? How can you train your regional healthcare staff? You can bring your regional healthcare staff in and give them a seminar and give them written instructions on how to titrate medications for heart failure. And you can begin to engage your staff in the overall long-term management of heart failure, because you really can't do this by just seeing the patient one time, giving them a prescription, sending them out and saying, see you in 3 months, because it's really not going to work. Heart failure management for survival benefit takes a lot of effort and a lot of people to actually improve these patients. Next slide. And the other thing that I want to remind anyone here is help is just a WhatsApp or a signal or an email away. There's a lot of us out there that are willing and able, and my phone will ring and I'll look down and there's actually a tone that rings that I go, oh, someone's having a crisis somewhere. I'm going to stop doing what I'm doing and pull up, and there'll be echo images, there'll be EKGs from somebody somewhere in the world that needs help with a problem, and we just walk our way through that and manage that patient. So I hope this has been helpful, and at this point, everyone listening on this seminar is now a cardiologist. You've all been recruited. We need you. Go to sign up, and we will send you to a WorldMed hospital somewhere in which you can use your new cardiology skills in treating heart failure. Thank you very much.
All right. Well, thank you, Dr. Spencer, for an amazing presentation. That was really thorough and easy to follow. I'm like you, I want some of that anti-heart failure tea. That sounds good.
I wonder if you take it prophylactic, will it work?
I bet it will. I bet it will. We better get a hold of that. But anyway, no, that was great. So Dr. Bob, this is a time that we dedicate to questions and answers. And so I'm just going to encourage our listening audience to utilize the chat box. And we'll start off with a familiar friend, Dr. Alan Sawyer. And of course, his question is relevant to obstetrics. And he was wondering if you could just talk a little bit about management of peripartum cardiomyopathy and resource limited settings.
Yes, for the postpartum, it's really not that much different than any other heart failure. You try to choose medications, and of course, what I do is I always look out to my obstetrician and say, can I use this drug? Because is it going to, and of course, I go look them up at the same time, is this going to be in the breast milk? Is it going to harm the infant? But postpartum cardiomyopathy treatment is exactly the same as all the others. Your relief of symptoms with their heart failure, and then you're going to start titrating up those medications. It's exactly the same.
Right.
And I think the only thing is the whole psychosocial part of that, which is a little bit more distressing for the patients and their families.
Great. Thank you so much. Gina LaFountain says, what percentage of people in resource limited settings can afford multiple medications and actually are compliant? And then do you see patients in those settings that have improved quality of life?
Yes, I think, there's two bits of this part about affording the medications. And that's the biggest part of what I'm trying to emphasize here is many patients can't afford more than about 3 drugs. And you're always, it's just like in the US dealing with a formulary, except there, you're not just dealing with a formulary, you're also dealing with, well, I went to this pharmacy and I could get this drug for $2 and I could get this drug for $12. And so you're always balancing what drug can the patient actually get. And I would guess that on average, your average patient can maybe get 3 drugs.
Yeah.
And then the question is, the next time they go, they can't get that one, they're going to get another one. So you're always running this thing about what they can get. Are they improved? Yes, they are improved if you can get the compliance. And the hard part of the compliance is many of these patients will travel a long distance. So then you're having to give these written instructions so that they can get a nurse in a clinic in the bush to actually titrate the drugs up for you, and then they can come back. So clear written instructions in their native language.
Right. Great. Absolutely. Just to add to that, Bob, maybe you can just comment how comfortable you are if you don't have access to like management or, excuse me, chemistries, electrolytes, butane and creatinine.
I'm very comfortable. I suppose I've gotten comfortable because I've been in so many places where there just isn't any. I mean, you might be lucky to get a potassium.
Right.
But you certainly aren't going to get a creatinine. So you really just roll with it.
Right. Yeah, I agree wholeheartedly. That's certainly a lot better than no therapy at all, right?
Right.
Yeah. Let's see, just I'm waiting to see if we have any other questions here. I just had one maybe unique to Latin America. What about Chagas disease? Have you seen any of that before?
Oh, yeah. I've actually seen it in the U.S.
Yeah.
So you end up with a cardiomyopathy related to that. One of my colleagues in Panama City sent me a patient for cardiac MRI. And it's like, okay, let's look at his history a little bit more. And he goes, oh, yeah, he's from Latin America.
Yeah, yeah. Yeah, so that's certainly, we want to keep an index of suspicion for that, certainly in, like you said, Latin America and even some of our southern states for sure, and maybe beyond, but very good. I don't think we have any other questions there. So again, that was a great presentation. I'm certainly going to utilize that as we remember management of both patients. Really, I learned a lot just for management for here at home, but certainly we can utilize that in World Med hospitals as well. So thank you so much. That was awesome. Just wanted to make a few other comments if there's no other questions. Remember, there's CME credit attached to this. You'll be receiving an additional email with the recording link. And so I encourage you to utilize that. As always, I always talk about all our archives of excellent presentations at health.samaritanspurse.org. Encourage you to go that, and you can, even with the recordings, you can get CME credit. So please utilize that. Invite your colleagues to participate as we are trying to grow. Just wanted to make a real quick comment. As many of you all know, unfortunately, prescription for renewal it was canceled due to the pandemic. We're hoping perhaps to offer something to you on a virtual basis. Yeah, unfortunate, but that's just the way it's going right now with this pandemic. So next month, we'll be meeting again virtually here at our webinar, Samaritan's Perth International Health Forum, Wednesday, September the 8th. Dr. Steve Martin, who is a pediatric oncologist, is going to be talking to us about oncology management and resource limited settings. So you want to make sure that you participate in that. And so, Bob, I don't see any other questions. So obviously you did a great job. Thank you so much for a great presentation and all your time and effort.
Thank you. It's been a pleasure to be here. And thanks for everyone for attending.
Absolutely. Thank you, guys. Thanks for attending. We'll see you next month. God bless.